Okay. Good morning, everyone. My name is Jill Flessing, and I serve as the chair of the Addiction Counselor Advisory Committee of the Kansas Behavioral Sciences Regulatory Board. Today is Wednesday, March 4th, 2026. I ask the members of the advisory committee to respond to a roll call to signify their presence at this open meeting that is being conducted remotely by conference call and by other electronic medium. Denise Sisman, Christina Boyd,
Here.
Lisa Carter, Jason Griever,
Here.
Chad Jacobs,
Present.
Michael James, Charity Cosson, Crystal Norman,
Here.
Dulcinea Rakestraw, Judy Reusser,
Here.
sorry,
Racer. Oh, that's
I will
fine.
get it, Zenova Williams.
Here.
I note the following BSRB staff members are also present: David Fye,
Here.
Leslie Allen.
Here.
Next, David Fye will read a message concerning the meeting being held remotely.
Thank you, Jill. This is Dave Fye, Executive Director for the Kansas Behavioral Sciences Regulatory Board. Public comment allows the public to address the advisory committee about any concerns, but the Kansas Open Meeting Act, or the KOMA, does not require the advisory committee to provide public comment or answer questions from individuals. Individuals requesting to provide public comment could contact the Executive Director prior to the meeting by sending an email to david.fye@ks.gov. There will be no public comment at this meeting as no individuals requested time for public comment. Because we are conducting this public meeting remotely by conference call and other teleconference ability, I state for the record the following information. Public access to this meeting is conducted by medium of interactive communication that allows members of the public without cost to attend the meeting through the use of the conference call and by viewing the board's YouTube channel. While the meeting is conducted remotely, the requirements of KOMA are not suspended. Therefore, we will be conducting this meeting pursuant to the KOMA. On January 26, 2026, we sent notice of the advisory committee meeting to all individuals who had requested notice of such meetings. The notice was also posted on the board's website, ksbsrb.ks.gov. You may obtain a copy of the notice at that website. An agenda and other meeting material have been posted on the board's website and are available for review. You may also request a copy of the agenda specifically by sending an email to david.fye@ks.gov with a subject line request for the agenda, and it will be sent to you. The notice contains information for the conference call and YouTube channel that allows the public to attend the meeting free of charge. The notice also states that if there are any technical issues during the meeting, you may call the board office at 785-296-3240 or send an email to bsrb@ks.gov. A recording of the meeting will be available on the BSRB YouTube channel following the conclusion of the meeting by using the link to the meeting on the agenda. The conference call line is active. I did check it before we got started. There's no one currently on the line, but if I hear someone connect to introduce themselves, I will let you know.
Okay, the meeting is now called to order. Thank you, David. And the advisory committee will begin its discussion of the first item on the agenda. And that first item is agenda approval. The agenda was emailed to you with a packet of information yesterday. If you've had a chance to review it, I would ask for any additions or changes, and if not, a motion for approval.
I'll make a motion to approve the agenda.
Can I get a second?
I'll second.
Okay, it's been a motion and a second. All those in favor of approval of the agenda say aye.
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 All those opposed, same sign. The agenda for today's meeting has been approved. The next item on the agenda is review and approval of meeting minutes from January 13th, 2026. Those were also included in the packet emailed yesterday. Does anyone have any additions or changes to the meeting minutes? And if not, may I get a motion for approval?
Motion to approve.
I'll second.
Been a motion to approve and it's been seconded. All those in favor say aye.
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 All those opposed, same sign. Minutes from the January 13th meeting have been approved. The next item is the executive director's report. David, I'll turn that over to you.
All right. Thank you, Jill. Um, I will focus a lot of my report this meeting on some of the legislative updates. I do try to keep you aware of BSRB activities. Just as a quick note on operations, Leslie and I have been scheduling a lot of meetings with different groups of students, connecting with them and talking to them about how to apply for licensure. Also trying to be preemptive and proactive when it comes to their expectations in terms of unprofessional conduct. There have been conversations about the role of regulatory boards and how it can be helpful in protecting the public. And so one of the things we're really being intentional about is talking to groups of students before they become licensed to make sure they understand what the unprofessional conduct regulations state, the differences between, an ethics code from an association versus things that are in law as a licensee, and sort of the expectations and how to avoid disciplinary violations. And so those meetings have been going really well. We've had several of those so far, and we will have a few more in the future. So if you know of any groups of students that would like us to do a presentation for those classes, please let us know, and we're happy to set those up either this spring or in the summer or in the fall. So moving to some legislative updates, the legislature is working very quickly this year. We'll touch upon a few bills, and one of the bills in particular is on our agenda today as a new business item to be discussed. That is the bill that would create an apprentice addiction counselor type license, House Bill 2506. So I'll focus on other bills for right now, and we can talk about that bill when we come to that part of the agenda. But one of the main items for the BSRB when it comes to each legislative calendar year, all agencies are required to submit a budget before the legislature. The legislature does have budget committees on the House side and usually Senate committees that review the agency budget submissions, take into account what the governor has recommended in terms of expenditures, and then make other adjustments as well. The last couple of years, the legislature has started a new process and had some interim committees meet in the fall to start to look at budgets a little bit earlier than the traditional process. And the legislature did that about 2 years ago and continued that this past fall. For small agencies like the BSRB that don't receive any money from the state general fund, they actually approved some interim committee dates for budget committees the week before the session started in January. And so our budget presentation was the very beginning of the calendar year. When the session started, the budget committee made a recommendation on the agency's budget, and I can pass along to you. They were very positive about the way in which we are conducting business, and they had positive comments about our budget as an agency, and that was recommended at the same amounts that we had requested in fiscal year 26, the current year, and then also fiscal year 27. And so those were passed forward to the House Appropriations Committee, and the chair of that committee reported out the recommendations from the Budget Committee, and the House Appropriations Committee confirmed the Budget Committee's findings and position on the budget. So that moved forward to the House Appropriations Bill. About 2 weeks ago, the House Appropriations Bill was run across the floor. That was House Bill 2434. And so the House has passed a budget. Just yesterday, the Senate debated their budget bill, Senate Bill 315. And so what the Senate did in terms of the BSRB is that if there were no significant changes from the amounts that were approved by last year's legislature, which was true of the BSRB budget and several other small agencies, they did not have a separate hearing on the agency's budget. So they basically carried forward what the House had recommended. And so their budget bill was debated on the floor yesterday for several hours. And then it was passed, but there still needs to be a vote called final action, and that is the official vote to pass the budget. So basically it's a two-step process. Usually there's about a day in between. So the Senate will likely take up their budget bill today and do final action. And if it has 21 votes, then that budget will be considered passed as well. What traditionally happens is the House and Senate pass budgets separately, and then they come together in a conference committee of leadership of both committees, and then they come to a final position on the budget. Now, in previous years, this happens much later in the legislative session. So I don't know that things will move as quickly at this point as they have in the past when we've reached this point in the budget process, but that's kind of what has happened in the past. And I think we're getting close to at least a time period where they can start discussing the final budget position. So it's interesting to watch. If you have any questions about that, feel free to reach out to me directly. But in terms of the BSRB budget, unless there would be something that would affect all agencies, I think our part in the budget process is likely resolved. The BSRB did not introduce or request introduction of legislation this year, so there was no BSRB bill. So we've been monitoring other bills, but in case you were wondering if the BSRB had introduced a bill, we did not this session. Concerning some other items, these are bills of note. So one quick item, if you're not someone who follows the legislature every year, the legislature does do 2-year sessions. And so bills are introduced either the first year of the session or the second year of the session. If the bill does not get passed or the bill does not expire because of a technical rule, any of those bills that are introduced the first year could be picked up and worked to the second year as well. But most of the time, the second year of a legislative session that usually focuses on new bills that are introduced during the second year. After the second year, all the bills that are still out there that have not been acted upon go away. It kind of kills the remaining bills. And so next year, it will start this process all over again. But for this year, I want to highlight a few bills for you that have been introduced and have had some action. One of those bills is House Bill 2352. That bill would require a duly ordained minister of religion to report certain abuse and neglect, except when reporting would violate the penitential communication privilege, and it would also require certain training in terms of mandatory reporting. That bill was originally scheduled for hearings in the House Judiciary Committee. Ultimately, it was passed from that committee. It was debated on the House floor and passed by a vote of 111 to 5. So the bill has been referred to the Senate Judiciary Committee. It doesn't directly affect our professions, but it is connected subjects, and so I thought it would be of interest for that. So that bill is currently in the Senate Judiciary Committee. I don't see that it's been scheduled for a hearing yet, though. House Bill 2420 is a bill that would require parental consent prior to the provision of any school-based mental health to a student. It was introduced by Representative Steele and referred to the Committee on Education. There was a hearing earlier this year in the House Education Committee. They voted the bill out favorably for passage with an amendment. That bill was on the calendar to be worked, but it was not worked. And so ultimately it was stricken from the calendar because of a technical rule. So House Bill 2420 essentially died this legislative session. So the contents could be picked up and used elsewhere potentially because language from a bill can have that happen to it. But at least the House Bill 2420 is not going to move forward this year because of the technical rule killing that bill. There was a bill that focused on the DEI topics this year. That was House Bill 2428. And that would require the State Board of Regents to establish curricula and designate courses at post-secondary educational institutions related to DEI/CRT related courses and content, and require the study of American institutions and certain programs at freshman orientations concerning free speech. That bill did have a hearing in the House Education Committee, and it was scheduled to be worked. I don't see that bill has had any further action on it, so at least as far as I've been tracking, I don't think that bill has advanced forward, but I will continue to track that bill. Let's see here. There is a bill that does not directly involve the BSRB, but it does involve another regulatory board, so we've been monitoring that. That is House Bill 2528. It has to do with the State Board of Nursing. There were a number of interim committees that met this fall that looked at some of the operations of the State Board of Nursing, specifically some of their decisions in terms of their disciplinary proceedings, and also what they do when someone's license is getting ready to expire in terms of the notifications that they provide to them, their ability to reinstate a license, those kind of things. And so that bill has advanced through the House. It was heard in the House Health and Human Services Committee. That was voted favorably for passage. It did pass on the House floor by a vote of 88 to 34. It has been assigned to the Senate Committee on Public Health and Welfare. We're continuing to monitor that bill, but that's the most recent update I have on that. There are a couple bills that are interesting in that they involve regulation of artificial intelligence. I know that's been a topic for this advisory committee and others. House Bill 2592 would create a Kansas task force on artificial intelligence and emerging technologies to study such technology and make recommendations to the legislature. That bill did get a hearing in the House Legislative Modernization Committee back on February 9th, but I don't believe it was worked by the committee. So I don't think it is likely that bill will advance this session, but I wanted to put it on your radar so you would be aware that the legislature did take a look at that. There is also a Senate bill, which is Senate Bill 405, which would make it unlawful for a person to knowingly train artificial intelligence to encourage or support suicide or the unlawful killing of another person, provide emotional support, develop emotional relationships, act as a healthcare professional, simulate human, or encourage isolation. And that bill did receive a hearing on Monday, February 9th in the Senate Fed and State Affairs Committee, but I don't have a note that that bill was worked or that it moved any further. So it was introduced a little bit later than some of the initial bills, so I'm not sure if that bill will move forward or not. But if you're interested in looking at how the legislature is starting to discuss these items, Senate Bill 405 may be a good bill of interest. And there is a bill that was just recently introduced. I don't have a lot of information on it, but Senate Bill 481 would permit a municipal judge to initiate a psychiatric or psychological examination to determine competence, and it would set forth the procedures for that. That Senate Bill 481 did have a hearing on March 4th in the House Judiciary Committee. So just looking for things that would involve the subject matter for our professions that we regulate or other items of interest based on our conversations so far. So, but yeah, the legislative session is moving very quickly. Generally, the legislature does try to meet for 90 days or less, but how they count those 90 days changes based on, the different administrations. But it does appear, at least from a budget perspective, that we are close to at least passing the initial budget bill. Sometimes there is a follow-up bill called an omnibus bill. If the legislature is still meeting towards the end of the spring, sometimes they do a bill that's based on remaining or new items. But then there's a number of these bills that are currently moving back and forth between the House committees and the Senate committees. So in terms of items from most recent board meetings, I am responsible for making sure that you are kept up to date in terms of those items as well. So I did want to let you know the board did have a meeting in January, back at the second Monday in January. The board continues to work through the unprofessional conduct regulations. That first meeting was on January 12th. The board also talked about the desire to put forth a strategic plan for the BSRB, a multi-year plan. That is not something that has been a historical custom, but I think it's a good idea. If you've been part of organizations, it provides good direction for that. And then the board had a special meeting on January 27th, and that was to discuss House Bill 2506, the bill that we're going to discuss later on today, as far as the apprentice addiction counselors. So there's just a couple of quick updates from recent board meetings. The board is going to be meeting this coming Monday in a hybrid meeting, and so the board will be talking about some new items as well. But with that, I'll go ahead and end my report and see if there's any questions on the legislative items I talked about, anything to do with BSRB operations or board topics or anything else you have questions about.
Thank you, David. Anybody have questions or comments? I appreciate you keeping us informed of what's happening. It's a lot. Looks like Denise Sisman might have. There's Denise. Good morning.
Good morning.
Okay, then moving on to old business, continued review and discussion of draft report of survey of licensees. We're on question 15 and 16, which are questions involving supervision, questions involving AI. David, do you just want to go to the item in our packet that is the responses and read over them?
That sounds good. I'll go ahead and share my screen here and we can talk about the summary responses and then also highlight that there are the open field responses you can go back and review as well in the report. So I will share my screen here and we can look at this information together. And then I'll turn it over to you all as a committee for discussion. Just kind of curious as we're working through these. Do you have any takeaways? Were things surprising to you when you looked at these findings or these survey results? Or did it match what you expected as well? So looking first at question, well, let's actually, for the supervision question, I'm just going to highlight the question before it because it also talked about supervision. For question 15 with the LCACs, it asked how many individuals you currently provide supervision to. And so on this one, you know, a lot of individuals that responded to the survey, the most prevalent answer was one. Some individuals responded with 2 or 3 to 5. Very few had more than 10 individuals they're providing supervision to. It was noted in some of the comments that there may be some individuals that are no longer practicing, but maintain their license for the purpose of providing supervision. So that may be some of the individuals that are providing supervision to a large number of people. But then also there was a drafting error in the survey because we did not provide an option for people to say they're providing supervision to 0 individuals. So that is why the prefer not to answer is likely so high, because individuals that would have marked 0, that was the closest option they could mark. But for question 15, we did ask the different levels of licensees over the past 2 years, have you experienced any negative issues involving supervision? If so, please explain. For the LACs, 110 individuals responded to the question. The most frequent response, which was 95 of the individuals, said that they had experienced no negative issues with supervision. So I do think that is worth calling out and noting that when given the opportunity to highlight something that was negative about their experience with supervision, the vast majority said they had no negative issues with supervision. So that is a positive thing. Of the responses identified negative issues involving supervision, one of the 2 main issues is a lack of real proper supervision. Some individuals said specifically reporting having direct supervisors who were not addiction counselors or poor support from supervisors and experiences with supervisors being unprofessional. Other comments that were noted were staffing issues. Specifically, there were issues reported with turnover, the shortage of addiction counselors, and providers being underpaid for the cases that they are managing. It is also possible, when we highlighted how many individuals expressed that they had no negative issues involving supervision, we did ask over the past 2 years, have you experienced any negative issues involving supervision? So potentially there may have been individuals who had negative interactions prior to that, but at least within the last 2 years, those were the responses we got. For LMACs, 91 LMACs answered the question. 75 individuals experienced no negative issues involving supervision, at least over the last 2 years. However, the most frequently reported negative issues involving supervision included unqualified supervisors, difficulty finding supervisors, or supervisors did not seem to have enough time for the individual supervision. Some respondents cite several supervisor-specific issues, including having supervisors who were unprofessional, disrespectful, overworked, unsupportive, unethical, and unwilling to provide solutions. In terms of the LCACs who responded to the survey, 160 LCACs responded. 139 individuals reported having no negative issues involving supervision, which is a very high number in my opinion. And so it's really positive to see that many that have reported no negative issues involving supervision. So when we do highlight some of the issues here, as I'm trying to kind of weigh both sides of this and make sure that we're stressing this, we don't want to overemphasize the concerns that were highlighted. We want to address these as things that can be worked on, but we also don't want to skip over the individuals that mentioned no issues with supervision too. But for the individuals who did express concerns or had negative issues with supervision, the most common issues were supervisees focused around neglecting self-care and having manipulation issues, or issues regarding supervisors focused on no-shows, last-minute session cancellations, untrained, unqualified supervisors. Other supervision issues reported included being difficult to find the time to adequately supervise, supervisors not being licensed in addiction counseling, employees engaging in unprofessional or unethical behaviors or practices, turnover, lying, the belief that the hour requirement for clinical licensure is too low, and that supervision is inconsistent and lacking structure. So, those were the summarized answers, and I do want to thank a couple members of my staff. They've been very valuable in this process. Emma, my assistant, and also Tyla, who's one of our licensing specialists, who primarily works with individuals submitting clinical training plans. Both of them have done an amazing amount of work to help summarize a lot of the survey responses. So I want to thank both of them for their work on that. But we also, in these questions in the survey report, we highlighted where you can find the responses from all licensees, and that is back in the appendices. So I'll turn it over to you. Considering what we just talked about in terms of the summary information, as well as the information in the back of the report, the open field responses, what struck you about some of these responses, or do you have key takeaways, or is there anything that you noted that may be something we can use to drive the work of the board or the advisory committee for the future? So I'll turn it over to all of you for discussion.
Can you provide some clarification on what is required of someone to provide clinical supervision for addiction counseling?
Yeah, and I think actually, so Leslie Allen is attending the meeting remotely, and she might be a good person to talk to because I think she works with our staff when individuals are getting lined up with supervisors. So, Leslie, do you mind going ahead and weighing in on that answer in terms of qualifications for someone to be a supervisor for addiction counselors?
The requirement for a clinical training plan is any clinical license by the BSRB can provide the clinical supervision or direction for the addiction counselors. They're not limited to the same profession because each profession may have training in addiction counseling.
And so that's just 2 years of post licensure, post of experience after obtaining clinical licensure.
Yes. Yeah. Sorry. They have to practice and be licensed for 2 years after the clinical license date, and then they are eligible to supervise.
I was wondering if there was a little bit of confusion on this because there's 2 types of clinical supervision. There's a clinical supervision for licensure, and then there's a clinical supervision that occurs within agencies. And so I wasn't really sure which responses or which of those kind of supervision capacities people were responding to these questions from, if that makes sense. But a takeaway that I kind of had, and this is also kind of just informed by my practice as a provider in the field, is that there seems to be a lack of training around providing clinical supervision and best practices for clinical supervision. I think within a lot of agencies, maybe less now, but certainly in the past, it's kind of next man up as far as who's on the clinical team when the clinical supervisor leaves. The next most experienced clinician becomes the clinical supervisor with limited training. And I just wonder if overall the field and clinical supervision across all disciplines might be improved if there's at least some sort of training that was required for people in order to provide clinical supervision. Those are my comments.
And I think, Jason, I mean, just in response to that, is that David, and you can help me remember, because it feels, I think I'm remembering that's kind of what prompted this survey in some ways, that we had started to talk about that, because some states do require, like Missouri, you're on a list, they have a list of supervisors, you have to take a certain amount of hours, because I think, as you just mentioned, definitely it looks like it's affecting people. That was one of the themes, I would say, that out of all of these, it seemed like, not having enough um, experience or unqualified, and then um, just lack of maybe some of those skills. Again, just speaking from my own experience, when I got my clinical license, there was no like training or preparation. It was like, you have the right license, you have the right credentials. Guess what? You're doing this. So I think that that's something that we have discussed and we're bringing forward, and then we're wanting to kind of get an idea from providers, was this something that was an overall theme, or was this just something that, again, individually we experienced? So I don't, David, does that sounding right? That was something that we had talked about, kind of prompted needs?
Yeah, I think a lot of the committees have kind of discussed that topic. So for two of our professions, marriage and family therapy and professional counseling, there is an official board-approved supervisor process, and individuals go through certain trainings and meet certain qualifications. And we have attempted to make that a requirement for the social work profession at least two times. That has come before the legislature in a bill, and it had been opposed by at least the state level association for NASW, because the argument that was put forward was that making requirements and having a board approved process would limit the number of individuals that could provide supervision. And so it's sort of been a push and pull in terms of, having a process in place appears to be a good mechanism to make sure that supervisors know what is their responsibility, that they're adequately trained to provide good supervision. On the other hand, it does decrease the pool of individuals that could provide supervision unless they go through that process. And as we've kind of looked at the professional counseling and marriage and family therapy processes, people have questioned the availability of the trainings for individuals to become board approved supervisors. But I do think it's a very relevant conversation, and other professions have been discussing this because there is a desire, if individuals are receiving supervision, they should be receiving good supervision. And we want supervisors to know what their responsibilities are and to be able to help individuals. We want that to be a beneficial process so that people can become good practitioners when they're out in the field, of course. But that's kind of been the argument. And so we haven't had other professions move towards a board approved supervisor process in the last few years, but at least that's kind of the track record that's kind of happened up to this point, is those two professions, professional counseling and marriage and family therapy, were interested in pursuing that was put into law. Social work, there was support for that at the advisory committee level. It was taken out by the legislature a couple times. So that's kind of where we're at right now.
And I think, David, I mean, I understand. I think, living out in rural area of the state, like it's very hard to find supervisors that are qualified and able to do it. I think that time piece comes in, and just how strained our systems are. I also think it's true when you look at research, when you look, I'm just working on some training, right? Like right before we got on this, around resiliency-based clinical supervision and the connections there between retention, preventing burnout, building protective factors. There's a huge connection with quality supervision, like you just mentioned, David. That if we have poor supervision, it can actually, it more of a risk factor, and that the burnout and people leaving the field and all those things, if it's not happening or it's not good. So I mean, I understand we don't want to put any more barriers in the way. I also think that having some level of competence, I mean, that's part of what we're trying to ensure. We just had talked about that. The board is here to, and licenses are there to ensure the safety of participants. I also think there's also, if we look through that trauma-informed approach, that part of taking care of people that are accessing services, also taking care of the people that provide it. And that has also a direct correlation to outcomes, that if people are burned out, they're not supported, if they don't have good quality supervision, that translates into not maybe the most competent services. And so I do think that this is worth talking about again, and you know, I'm a licensed social worker as well. And again, I understand that piece of it. I think there's a bigger picture there too. I also think that part of the problem of finding supervisors is that we don't have any kind of a list. We talked about that for years. That people call me and are like, you know, if I'm able to do it or not, and then I don't know who else is, you know, like we don't have a really great way of keeping track of that. And so it it seems like if there could be some things we could, you know, I'd be interested in what other states that do have these kinds of things, or like you just mentioned, David, has the number gone down? Is it truly a barrier for those disciplines that have created some sort of licensure training, you know, kind of requirements? Has that actually decreased the number of supervisors, or is it, you know, we're saying this is a barrier, but is it actually a barrier? Is there ways to support that? Are there ways to, you know, some sort of trainings that are free or easily accessible, or, you know, I think there's ways you could make that, you know, if trainings are offered, you know, is there some flexibility in what kind of training, as long as they cover certain competencies, or, you know, how that could be set up so that it doesn't have to become a barrier and could actually be a benefit to those that are receiving that supervision. So anyway, just my thoughts. I'm obviously like, I think this is so important. I really feel like supervision has a huge connection to the health and wellness of our workforce. And we want to make sure it's supporting it and building those protective factors as much as we can.
Right, and then not just health and welfare of our workforce, but then of everyone that we're serving. But so you mentioned that the marriage and family therapists and the professional counselors have a process for approval to provide that clinical supervision. Are there any, does that create any obvious barriers? Is there a cost barrier? Is there what's required for them?
And Leslie, could you weigh in again? Leslie is the individual who kind of keeps track of the list of all of our marriage and family therapists and professional counselors who become board approved supervisors. And so, Leslie, do you mind weighing in a little bit on what someone would go through to become an official board approved supervisor, and maybe ballpark we have in those areas? So.
Currently, both professions require 15 hours of continuing education in supervision, and they have to do for renewal, each renewal, they have to do 3 hours of CEUs in supervision, of which one must be ethics in supervision to maintain their board approval. The we really It depends on the profession. It doesn't seem to have much of a negative effect for marriage and family therapy, but there are more professional counselors, and sometimes they say it's difficult to find a supervisor. However, the board has changed the regulations so that all supervision can be done via televideo, which allows people to find supervisors who are not in their area. So that's kind of where we're at currently.
Sure. So what is the upfront requirements? So in order to become a clinical supervisor, what are they required to do other than beyond having that 2 years?
They have to have 15 hours of continuing
Okay.
education and supervision, or if they've taken a 1 hour graduate level supervision course as part of their degree, or afterwards, they can use that in lieu of CEUs. And
Okay.
then they apply and it costs $20.
Okay, and then after that, it's for each licensure renewal period, it's 3 hours of ethics and supervision.
Right. And it's just renewed with their license. There's no fee after the initial 20.
I really like that structure. And I agree that now that, you know, supervision can be provided virtually, I think that takes away a lot of those barriers, or at least improves access. Christina, as you're mentioning out in Western Kansas, where supervisors may be fewer and further in between, if there is, a list of folks from whom they can receive supervision, then that would certainly make it a lot more accessible to folks in Western Kansas.
And Leslie, is that list accessible by people that are wanting to find? How do they go about finding them? Just you give them a list, or they make calls, or?
There is on our website under general forms, there is a mailing list request form, and they fill that out. And there's a checkbox where they check that they want this profession's board approved supervisors. And they have to sign. The reason they have to ask for it is it's considered an open records, and they have to say they won't use it, to sell their products or something like that. So they send that to us, and then we email that list in an Excel spreadsheet. And usually it's done the same day or the following day after receipt. We have talked about putting it on the website so that it's available to everyone. The issue is that we have phone numbers and emails and addresses. So we've kind of hesitated following through with that.
And Leslie, also what you talked about, there's a statute that says we will share certain information as it's, the business contact information for individuals, but individuals also need to say if they receive that information, they're not going to use it for purposes contrary to the law. And so the way that we can get that agreement is by having them request the form and acknowledge that, and so they're not going to use it for purposes they're not supposed to. So,
Leslie, can I check one thing that I think I heard you say?
Sure.
So to provide clinical supervision for the LCAC license, that supervision can be provided by any practitioner in any discipline that has achieved clinical licensure?
Yes.
I don't want to put up more barriers to anyone, but does anyone to the field, but does anyone else have concerns about that? Because I can think of a lot of independent practitioner colleagues that know not very much about addictions work.
I agree with that completely, Jill. And I think that if there was that training requirement, then at least those folks from the other disciplines would have some exposure to providing clinical supervision within substance use.
I think there is some, and I don't know, this is just kind of thinking about this critically, that when the state had moved towards like the LMAC acknowledging that approaches, skills to providing services to human beings in this area, that those skills are transferable, and that there is something, I think, and Leslie, you might be able to speak to this, that you have, when you are a supervisor, I think I remember, there's a piece on there that you have to say you have knowledge and competence in the area of practice that you're going to be supervising that person. So you do have to attest to that.
You do.
As part of that.
Yes, you're correct. I was just going to say in the regulation regarding supervision, one of the items is that you have to have experience and knowledge in the practice area that your supervisee will be providing services. So there is a little bit more, when you get into the training plan where you have to show your knowledge and things like that.
Is this something we want to continue to discuss in the future? Is it something we want to make a recommendation? What would we like to do from here?
I'm wondering if we could get, David, again, just that information about the disciplines that have, the two that already have those, if we could maybe get a little more information about what they actually, their statute, or, what the requirements are. And then maybe just, again, I would just be interested in maybe knowing how many supervisors they've had on those lists, like since that came into, before they did that and after they did that. Has it gone up, down? Has it stayed the same? Is it really creating barriers? And then I'm also wondering if we have relationships with like Missouri being a very close state that has some of this as well, what they've seen or like what they've done, like what their requirements are, just to kind of see what might be an example. I don't know the easiest way to go about that. I don't know, Dave, you have like, again, relationships with their board, or if somebody does, we could reach out, but maybe just gather more information so that we have good information to maybe have a little bit more discussion on it.
Yeah.
I think that giving you the information is, we can definitely do that. The one thing is, before we had board approved supervisors, we didn't have a list. So we can't tell you what the list was before. We can only tell you what it is now.
Yeah, that makes sense, Leslie.
I think I was going to say something similar. We might be able to ballpark potential supervisors, but not necessarily if all of them wanted to supervise or if they were actually providing supervision. So, yeah, one of the things with having board approved supervisors is we do have a list that can be pulled. And we did an exercise. I think Leslie did this maybe 2 or 3 years ago now. She sent a message to all the individuals that were board approved supervisors to ask them, are you still interested in accepting new supervisees? And not everyone responded back, but she did get sort of an updated sub list that were not only individuals that were board approved supervisors, but those that were actively looking for more supervisees, because there had been some reports about, maybe someone got the list and they started making a few phone calls, but nobody was taking new, supervisees. So that was something helpful we could offer in addition. But, with the professions that don't have board approved supervisors, we don't have the list to begin with, let alone necessarily knowing who wants to provide supervision or who's available to provide supervision currently. So
Is that, oh, go ahead, Leslie.
I was just going to say, I think one of the things we hear a lot when people want to use someone outside their profession in the others is the cost. The cost of supervision is upwards of $500 a month. And if your agency can provide it to you as a perk of your position, then people are concerned that they have to pay to go out and seek outside supervision. So that's one of the things we see a lot with the board approved supervisors when they request something else.
And that can work both ways as well. On one
Yeah.
hand, the person who would normally be paying for supervision, they get sort of a discount. And then also what we've seen with some of the facilities, they have the ability to pay their employees a little bit extra to provide that supervision. So it's a retention type thing, both the recruitment thing for new employees and also for existing employees. So there have been a lot of individuals that have wanted to use that in certain ways. The question is, did they meet the qualifications and did they fit sort of the structure of who we're able to approve as supervisors currently? So
Would there, and maybe this could be part of the discussion too, I'm wondering, at the very least, like being able to continue to have lists of the supervisors, like even if we didn't say there was a requirement to have training, could there be a list? Like I could see there being a benefit of that if there was like a compromise, or like if we decided we do want training, that's one thing. Obviously, there would be probably a list that we'd have. On the other end of that, would it be beneficial still to have a list, even if we didn't require training? I do think that there could be some benefit in having that for supervisees, so they're just not. I mean, I think after you've made 2 or 3 calls and people are saying no, or they can't, or whatever, or they don't even know where to start. I've had people contact me and I don't have another name to give them. And so I guess that could be maybe part of our conversation too, if that's possible. Again, I don't know what administrative burden that puts on Leslie or, the board to do something like that. But I guess that was just another thought.
yeah, we've talked about adding a question to our renewal form to ask, are you currently providing supervision, or are you interested in providing supervision? Would you like to be added to a list? And basically having people do that. The part of it that, we currently don't have a mechanism to group all those people together with our existing licensing system. So it would be a manual process that would be pretty time consuming to go through all of those renewals and put together that list. But we are about halfway through moving to a new system, and potentially with our new system, that might be something they would be able to automate for us to gather that information. So maybe in about a year, we might have that capacity. We're hoping to be moved over maybe by the end of the next year. But yeah, I think that's one thing we've talked about as a way to kind of get some updated information on who is interested in providing supervision.
Okay, so gather some more information before next meeting about the
So is
MSP.
that-
I'll work on making a document for you with our current requirements.
I appreciate that, Leslie. Thank you.
Thank you
Everybody
very
else
much.
okay with that?
Yeah, and I didn't hear for like contacting Missouri. Is that something one of us needs to do, or is there again some relationship that you will have with them?
Yeah, I can reach out to some of our contacts in Missouri
Okay.
and get some feedback from them on how things are going over there, or similar things they have in place. So,
Okay,
Thank you.
thank you.
Okay, moving on to question 16, use of AI in practice.
okay, I'll go ahead and share my screen here. So this is page 33 of the report. It focuses on question 16 for the LAC and LMAC, and 15 for the LCACs. It said, do you currently use artificial intelligence in your practice? And if you do, in what areas do you use AI? So for the LACs, 127 individuals answered the question. The most frequent response, which was 103 of the respondents, was from licensees who do not use AI in their practice. However, after they said, I don't currently use it, some individuals did mention needing to learn more about AI before using, and others reported looking into AI in the near future. It's important to note that the time period we were looking at for this survey was about a year ago now. So it is possible that things may have developed and changed over the last year, but at least this was a good point in time information for all the professions. 7 individuals did indicate they use AI in their practice. Specifically, some of the areas they use AI include note taking, treatment planning, and trainings. For the LMAC responses, 107 LMACs answered the question. The most frequent response, 88, so a lesser number, but still a high number relative to the total number of respondents. 88 individuals noted they do not use AI in their practice, but after providing their response, some mentioned planning to implement soon, while others believe that AI use is unethical. Some licensees also expressed not wanting to use AI because their clients are not comfortable with the use. The use of AI that was reported includes notes coming up with ideas and documentation purposes. One respondent noted that while their practices implemented the use of AI, they remain distrustful of it. And then for the LCACs who responded, 187 LCACs responded to the question. 34 individuals said they do not use AI in their practice. But after providing that response, 4 individuals said they are actively working to implement AI use. 3 reported being interested in it. Other licensees followed up the answer by stating the best practices need to be established before they would be comfortable using AI, and 2 expressed having no interest in AI use. For the individuals that were interested in using AI, for most common response was for note purposes. Less commonly reported, but also included, were treatment plans or reports, grammar or formatting, research or information gathering, documentation, or generating handouts or educational materials. And then it was also stated that insurance companies use AI to review documentation. So any clinician accepting insurance is exposing client data to AI technology. Furthermore, 3 AI platforms were named by licensees who use them. These platforms were Elios, Adobe, and Therapy Notes. So as I mentioned, this information is about a year old now, but one of the benefits of doing this survey the way we did it is we do have point in time information. So if we ask a similar question in the future, we can kind of compare where we were at in 2025 compared to where we were at in the future. So, and then also the survey does reference the appendices with the open field responses. So if you wanted to see the specific answers individuals provided, you can see that. So I'll go ahead and turn it over to you if you have any comments or takeaways based on the feedback on the use of AI in practice. And just to kind of ask, I know we've had some maybe greater acceptance of AI over the past year, or at least maybe exploration in the use of AI, at least on a personal level. Some individuals and other committees have kind of talked about that a little bit. Were there platforms you expected to see if you have some familiarity with AI that you didn't see? There was mentioned Elios, Adobe, and Therapy Notes. Seeing Adobe referenced here, I think has kind of brought up a point some of the other advisory committees have talked about, that perhaps there may be some technology individuals are using that they don't realize has artificial intelligence included in that. So that is definitely part of the conversation, but some of them definitely are purely an AI tool. So what do you think about the AI tools that were referenced, or the way individuals were using AI there, or the range of opinions? You know, some were saying we're not using it now, but we're actively working on it and researching it. And then on the other end of the spectrum, some people were saying, I believe use of AI is unethical. And so just kind of curious your thoughts based on all these responses.
It is my understanding that the field of AI is moving so quickly that these responses are about a year old, actually is kind of what I would expect, that there's a spectrum of people that are like, go for it. Yes, let's move into the future. And people that are very distrustful of it and everything in between. I mean, I work for KU. KU has rolled out Copilot, which is a Microsoft product. But my little agency within KU, by policy, it's still a no-no. Yes, we are looking at it. I know lots of closed EMRs are using AI for progress notes and treatment plans. I don't know their names because they're not ones that we are using right now, but that doesn't mean they don't exist. I'm curious what y'all's thoughts are. I just know this is a field that is going at light speed.
Yeah, I know there's EHRs. We utilize an EHR that has AI capabilities. We're still kind of exploring and seeing what that's going to look like for us, but it pulls stuff for like ASAM notes or documentation or treatment planning and stuff for like UR billing purposes, that type of, I think that was mentioned lower in the document also by somebody else. So, and we've seen staff kind of with all the different perspectives, but the overwhelming majority of them are excited because the amount of documentation required from staff these days is so much that they feel like they spend most of their time focusing on documentation instead of patient care. So it does require, so when we've been playing around with it a little bit, it does require going back in and reviewing it. I mean, and I think that's where that ethics piece goes. You can't just have AI do something and then not review it and sign off on it. I think you've got to have some kind of oversight and reviewing. I mean, you're putting your license and your name to what's in that document. So and it does make mistakes sometimes. So going back through and just making sure everything is accurate and that you're willing to sign off on it, I think is an important piece.
I agree with everything that's said. I mean, I think most major EHRs and EMRs now have an AI component. I know that some of the different CCBHCs are adopting some different AI infrastructure. I think it's inevitable. I think we're very fortunate because from what I have seen and understand, and it's been something that I've been kind of following on behalf of the organization I work for. But Christina Boyd is kind of the state expert right now, I think, on at least ethics in AI as it relates to addictions. She had given a presentation for CAP, and so I think I defer to her on just about anything related to AI. But I also, going back to the stuff that was handed out last month, I was really impressed by what Illinois had come up with for their Wellness and Oversight for Psychological Resources Act. It was pretty high level, but I think it provides a good framework for beginning to have some structure around AI. It had bans the AI only therapy, prohibits misleading advertising claims, makes professional oversight required, allows AI for admin or support, but only under human review. So I think if we're looking at doing something, as far as putting regulations in place or statutes in place around AI, from what we were sent, I liked best what Illinois had come up with.
Well, I think, what Jill was saying, what Jason has just said, there's so many implications, because I think it's also the ethics. So when we talk about ethics, it's not only what are providers using, but it's also what the clients, the participants are using, how they're using it. And I think that gets into, Jason, what you were saying, like having some of those guardrails to try and protect the public, maybe outside the purview of what we're doing. But I think having knowledge and understanding of this, Jill, you'd said there's early adopters, there's abstainers, right? There's everything in between. And so the need possibly to acknowledge that this is here, it's happening. The amount of progress that's been made, like you just said, in the last year, I can't imagine in 5 years what we're going to be talking about, right? And so I think this is good to look once again, maybe like Jason mentioned, what other states are doing, what makes sense to have some guidance and some protection, and understanding that it also has to be somewhat broad because we're going to be changing it every 6 months, some of these things. So, I don't know that there's a clear, right, wrong, especially with all of this. I know in the space of preparing students who are going to be entering the field this year, they are using it, and they are using it sometimes in ways that makes me nervous. And then they're also using it in ways that's pretty creative and helpful. So I think that's what we're facing in that space, is how do we prepare students to do it ethically and responsibly? If this is something that's there, how can we teach the principles of ethics around use related to the ethics that we hold already, And so knowing, like Crystal just said too, that maybe there is, some administrative burden. There's some ways that this does create better clinical opportunities that we can spend time doing this if we don't have to do that. I just think there's a lot of fear and unknown. And so it is a lot of trying to assess what is real, what are the applications, how can we in some ways put guardrails, but I mean, there's going to be things that we just don't even anticipate, I think, with all of this. So it's hard. I'm glad we're having these conversations. I don't know what that means for our state. I mean, again, I know Becky had already had presented testimony to the legislative body around some of this, around AI for social work. And was that shared, David? I know she had shared that. For purposes of training, and we had through CSWE. But again, just looking at some of the implications, I guess, of how it's being used. There are so many lawsuits already that are happening right now across the country because of deaths that have occurred, and AI being implicated in that, mostly open chat, GPT, that sort of thing, open AI. So I don't have a clear, like, we need to do this. I wish I did, but I think it is worth continuing to discuss and looking at, does it make sense to make some recommendations around. And was that in the last email, David, about the Illinois? I don't think I saw that.
I think it was in the packet of material from the last meeting.
The last meeting. Okay. I'll go back and look at
I
that.
had summarized 3 laws that had passed in 2025, one in Illinois, one in Nevada, and one in Utah. And so there was also a copy of those bills behind that. And so, but
I don't think it's going to go away. I mean, I think
No.
if there's concerns about safety or ethical implications, that I think staff are going to do it or patients are going to utilize it, those types of services, regardless of what we decide, and that it's better to try to find safeguards and establish ethical guidelines or requirements ahead of it, knowing that it's kind of like, I remember when I was in school and they're like, you're not always going to have a calculator on you. Yeah, I do. I think this is going to be something similar to that. Jason, you know what I mean, don't you?
That is the best analogy I've heard. I love it.
Abacus, no. Calculator, yes.
yeah.
I think we've kind of moved on to continued discussion of regulation of artificial intelligence, which is the next item on the agenda. I guess I am curious if y'all are, if David could share with us what other advisory committees are discussing. And, we're talking about putting guardrails on this process, but is anybody coming up with anything concrete?
Yeah. So, in terms of legislation on this topic, there will probably be other entities that will spearhead that effort if it's going to be something that would affect a lot of different agencies. But in terms of unprofessional conduct, I think that may be the best approach. In terms of, not necessarily restricting what AI can do, but basically saying if you are a practitioner that is using AI, here are some things you need to be mindful of. And so the other advisory committees, it seems like most of the conversations, they've gone in different directions, but they've kind of come down to about 3 main areas of focus. And 3 of the advisory committees recently made recommendations to the board. So I'll just kind of highlight those 3. And yeah, both advisory committees have something very similar. Their language might be just a little bit different, but the concept would be informed consent. So if you are using artificial intelligence in terms of your practice as it relates to client care, you need to make sure that clients are informed you're using AI, and then also that they need to be informed how you're using it. So that doesn't necessarily mean that if you're using it for any operation, you need to tell them about it. You don't need to tell them that you're using it for marketing purposes or to help with your budget or things like that. But if you're using it for client care, it seems like the other advisory committees had held that there's an interest in making sure that clients are informed you're using it in terms of client care and then in what ways you're using it. The second area that the advisory committees have kind of focused on involves confidentiality. That if you are utilizing AI in terms of client care, that you are doing your due diligence to make sure you're keeping confidential information confidential. And that involves things like responsible use of technology and things like that. But informed consent is the first piece. The second piece is usually confidentiality. And then the third piece that a lot of the advisory committees have kind of settled on as a recommendation is if you are using artificial intelligence in terms of client care, that you provide an opportunity for clients to opt out. If they're not comfortable with the use of AI for their care, that you provide a way for them, not only that they're informed and you're keeping the confidential information confidential, but that you provide an opportunity for them to opt out of AI being used for their care. So those are what the other advisory committees have discussed so far. Like I said, I think there's 3 of them that have officially made recommendations. Others have basically talked about these topics but haven't made official recommendations yet. But those are the 3 areas they've focused on.
David, did they talk about how would you opt out, like as in practicality, like for agencies, how would they tease that out if it's part of a overall system that's maybe aggregately or is using, depending on the use, but I would see that would put, I don't know how that would be, I guess, in practice, like practical ways, how you would do that.
Like an
if someone actually
administrative
opted out.
burden on who
Yes.
is, who isn't.
Yeah.
Yeah, and that third one doesn't have the same level of uniform support with the different advisory committees because that has been talked about. One application might be if you use an AI product to listen to session and take notes. Maybe if someone says, I'm not comfortable with that because, I don't know that it's going to be a closed AI and that you are controlling where this information is going or that it's going to be deleted after the session. Um, perhaps there would be a way for someone to opt out of that being used. But then again, there's questions about what products are listening to things that we don't realize are listening to things. And, what if it is so embedded in your techniques that it wouldn't be feasible for you to allow the person to opt out? And those have been just topics people have mentioned in other advisory committees. And I think those are relevant points. I think if there was ever, if you start to go down this path of unprofessional conduct and there is a complaint regarding the use of AI, I think the members of the board that would sit and would be hearing this topic would have to kind of weigh the reasonability. Is this something that you have the ability to control? So I think ultimately that if this is the direction the board goes, there'll have to be things that are weighed. But the points that you brought up are very good points because other committees have talked about those things too. What if there's not a way to provide the ability for someone to opt out of that? Do you want to put them into a position to where you say you'll have to find another provider,
I guess I also think of the alignment with just technology in general, right? That there's been, I mean, Crystal, that is such a great, I'm going to totally steal that if that's okay, about the calculator, right? Like there's been fears about different things throughout the years. Televideo, we had a huge phone, all these things that there were fears about. And then it took some time for the research, the evidence to kind of back up. We had this opportunity, unfortunately, with the global pandemic that kind of put a big, huge N number out there that we could really study those kinds of things. But I guess I wonder again about getting so focused on, to me, it's not that it is different in some ways, but it's still the age old question. How do you apply the ethics that we have to the technologies that are now available? And how do we prepare and ensure that people are being ethical in their use, whatever the technology is? So whether it's telehealth, whether it's AI, whether it's the next thing that's going to come. You mentioned, David, we have these little smart computers that we sometimes make phone calls on. If you have a Google Assistant on there, it's listening all the time, right? Like there's things that people just, again, need to understand. I feel like it's a competence issue in and of itself about technology, if we're going to use it or not use it. Like, I think even with abstaining from use, do you know why? Do you have a clear understanding? Is there, that you could, articulate what is it that is, to you, is the reason, not just I'm scared and I don't understand it. So I don't know. I guess I also think about being so prescriptive, again, the need to keep things in a realm of understanding that how quickly things are going to change and how often do we want to be changing statute. And if there is something recommended, does it make sense in context of evolution? And some of that we just can't predict. So that, you go with what the information you have at the time. But I guess that would be something I would just maybe think about as we move forward, trying to make recommendations that make sense for the foreseeable future, maybe. I'm thinking out loud a little bit. I'm gonna stop, let others.
I don't get the idea that we feel like we're in a position to make recommendations at this point. But I could be wrong. Anyone thoughts?
The only thought that I have is kind of the thought, I guess, from like, yeah, training students, as well as like leading in from question 16 and also the regulations. And I don't have like a, a recommendation, but the idea that we see, especially like in training students, is when we're training the skills, right? And trying to figure out, do the students have the information and the gap between learning that skill and applying it? And so like they might be using or trying to use AI and they're not understanding the difference because they don't have the skill yet, or they don't have the information, the knowledge yet. And they might be trying to use AI to bridge that gap. So they don't know that if they pull it from AI, they think, okay, that's correct, but they don't know that it's actually not correct. And we, of course, we know that it's not correct, but they can't tell the difference sometimes. And so we're trying to teach them how, like, okay, like for instance, like let's say if you're in education, if you create your own lesson plan versus you generate one off of AI, do you know the difference of like, is this a good lesson plan versus like, why is yours better, or why can you improve yours, and how can you better those kind of things? And so training students or trying to help them learn that skill and that skill knowledge, that skill gap, and the knowledge to be able to do that versus just trying to think they can just like generate it off of AI, like, okay, well, that's good enough knowledge. That's what we're seeing in the educational background. And so I do worry about that, I guess, thinking about that in the field, that maybe are people going to like use this to like think that they're going to extend their scope of practice or their scope of knowledge beyond what that's actually they're capable of? Um, kind of thinking like, oh, okay, well, I can just, even though I may not know something, maybe I can just kind of Google some anxiety skills or something, even though I don't know about that. But those are just kind of things I think about. But um, yeah, in my fears and I think about those kind of things. So I do think about that for like regulating AI and what those uses are when I think about clinical things, when we think about practice. So
And Nova, I feel like that brings us right back around to that quality supervision, right? Like I mean, part of this is having supervision in the field when these things come up, to be able to look at that skill, to be able to review those interventions and notes and those kinds of things, to have that human element be part of that. Um, I feel like that's one of the safeguards. That's why we have supervision. That's why it's required, right, as part of your development as a clinician, or as you provide services to other human beings. So, I mean, I do think these are interrelated in some ways that when we look at that. So, yeah, these are tough questions. I don't know, Jill. Like, I don't feel like I could make a recommendation right now, personally. I think if we continue to have it on our agenda and be discussing it again, as we maybe look at some of these other things and review, and um, maybe that would make sense to continue those conversations. I don't know what others think.
I thought the same thing, Christina, that I made the connection back to supervision. And I wonder if there's an opportunity to look at, there is I think I heard 3 hours of continuing education every renewal cycle, one of which had to be in ethics. If we would want to look at one of which also has to be in artificial intelligence, because it is changing so rapidly that it would be good for all of us actually to have some kind of training on a regular basis. And that might be an opportunity to really emphasize the importance of AI and be knowledgeable of what it can and cannot do and how you want to be safe.
That ethics requirement is across disciplines. Yes.
There's a 3-hour ethics requirement, just the general CE requirement. For the supervisors, I believe it's 3 hours to maintain that. Yeah, 3 hours in supervision, and one of them is ethics of supervision, I think, for the board approved supervisors in those categories.
Okay. So.
I do think there's something there with, oh, just real quick, what Denise, you just said about competence, right? If we're looking at competence, I don't know if we would want to get, again, so prescriptive to AI, but just technology, right? Could that be technology? I feel like that is a competence in our world today, and that includes digital footprint, how you show up in social media, how, I mean, there's so many ethical implications of that, and boundaries and self-disclosure, as well as telehealth and having competence in that, that so many of us, again, are, were thrown into that, or individuals will talk about, they were providing therapy over a computer, like because they had, had to, not because they had training. And so I guess I wonder, just again, broadening that out to maybe just technology, that being a competence. Do we really feel like that's a competence of providing services today?
Like that. I like that a lot. We see that a lot with staff, where especially it's not just AI, like you mentioned, social media and other things. And when they're coming straight out of school, a lot of times they struggle with where those boundaries lay and how to utilize that technology, I think. So if there was something broader that as technology changed, it could still, like you said, it's not super prescriptive, so it doesn't tell you exactly what it is, but it can encompass that as it changes.
And I just want to be transparent here. This is definitely something I feel very strongly about. Like, I've done training on this for years because I feel like it is such an important need. So I'm probably a little biased in this discussion. And there's, evidence to that. I mean, I feel like, back in 2013 when we were trying to do groups over Zoom and doing them very poorly. Like, I will admit, like, we did not know what we were doing. We were really trying to build the plane at that point, while we were flying it. So I do think that having supports around that, and then I guess that gets to, is that a mandated thing? Does the board need to mandate that, or is that just good practice that people know they need to get that, right? And we've had those discussions before. If we start being so prescriptive on CEUs, then does that create barriers, or does that create some issues in and of itself? I know we had talked about that back before this year, talking about uh, different aspects that maybe could be required, or around diversity and equity and that sort of thing. And and had some of those same discussions about what's the priority, that we say, yes, you have to have this, or again, do we just leave it up to people to determine that clinically what they need?
Okay, I don't want to run short on time today because I know we have a couple other important items on our agenda. And I know Leslie's here. David, do you want to move on to continue discussion of making up practicum hours for license?
Sure. I'll just make one last comment, kind of related to the survey. We've been doing a really good job of going through these questions together and having good discussions. Basically, there's 2 questions left on the survey that you could be reviewing in preparation for the next meeting. And then we will have gone through a lot of the big questions that other advisory committees have looked at too. So in preparation for the next meeting, if you could look at the last 2 questions on the survey. There's one that says, based on your experience as a licensee in Kansas, do you have any recommendations on additional ways the BSRB could protect and serve the consumers of services offered by BSRB licensees? So that is one of the last questions. So if you could look at the summary information on that and the open answers in the back. And then we basically asked a catch-all question, question 18 for the LACs and LMACs, and 19 for the LCACs. We said, do you have any other comments or feedback you think would be helpful for the members of the Addiction Counseling Advisory Committee of the BSRB to receive when evaluating possible changes to the statutes and regulations for the profession? Please explain. So if you could be looking at that information, we can have a similar discussion next meeting. So just a little bit of homework. But yeah, I'd be happy to move on to the next topic if you'd like me to do so.
Please.
Okay, well, I will probably turn it over to Leslie for most of this conversation, but at one of our previous meetings, we talked a little bit about individuals being able to make up practicum hours, and Leslie was going to bring back some language for you to look at. So she did provide a document, and I will share my screen here so you can take a look at what she put together. And I'll turn it over to Leslie, and she can kind of describe the language here in KAR 102 7-3, the educational requirements.
Gotta unmute. Okay. So what I did was I took language that we have used in marriage and family therapy statutes that allows the makeup of practicum hours, because their amount of hours is in statute. Addiction counselors is not. It's in regulation, specifically the education requirements. So I just copied the part of the regulation that was pertinent because it's a very long regulation. So I started with the LAC. Each applicant has to have these courses. And if you scroll down, Dave, and in their practicum, they have to have at least 400 clock hours of practice, or a combined, and I added, or a combined 400 hours of practice hours and additional post-degree supervised experience. So that would allow them to take however many they got in their practicum, and then when they apply, be approved to get a provisional license, and they could do the additional hours after their degree. And then for the master's level, they have to complete all the courses, but their practicum, there you go, on the second page, they have to have at least 300 hours of direct client contact, or a combined 300 hours of direct client contact and additional postgraduate supervised experience. And this is, again, language that's been used in statute, and it's also been used in other professions where they have to make it up. They have to make up direct client contact hours if they didn't have enough in their practicum when they get their clinical license. So that's what I thought would work best. The post degree for the LAC may have to be worked on, because it could be part of it could be their degree, or it could be where they have their degree and they go back and take addiction counseling courses. So that may have to be, I may have to add a little bit of additional language, but that's what I have so far.
So I guess the question for you today is, we've talked about this conceptually in terms of people making up practicum hours. Is this method that Leslie put here in some language for you to review, is this something that you feel comfortable recommending to the board as a change to the regulation? Or do you have any questions? I'll stop sharing my screen. But yeah, if you have questions for Leslie about the language here or anything else, I'll turn it over to you as a committee.
I think it seems very reasonable, but what do you all think?
Yeah, there were a question about practicum hours. It was always educational credits, which can't necessarily be completed outside of an educational institution, whether it's Washburn or any other educational institution. It doesn't matter which one, because it can't, if it's not an educational institution, they can't provide with transcript. And so that was the concern that was there. Because otherwise, what's the point there? Otherwise, it doesn't matter where they get it from. But yeah, as long as they can do their practicum hours anywhere, we're perfectly fine with that. That's a great option for people. That provides a lot of flexibility for people.
David, is this something that the committee needs to give a vote on?
You could do a vote, or it could just be the consensus of the committee for it to move forward as a recommendation. So,
what do you think about consensus to make a recommendation to the larger board that this language move forward for makeup of practicum hours? Folks seem to be nodding. Okay,
appears to be consensus.
appears to be consensus.
Okay, we will move it forward.
Thank you.
Yeah.
Thanks, Leslie.
Yes, thank you.
Sure.
In the half an hour we have left, moving on to new business, I am going to turn this item A over to David, who a discussion of House Bill 2506, because he has the history, the movement so far, and where the bill is now and will be able to frame it much more eloquently than I can.
Well, thank you, Jill. I'll just kind of set the stage here, and under new business, item A and item B may have a connection. I'll kind of leave it for you as an advisory committee to kind of consider that. But to frame it here, every legislative session we track bills that are relevant to the professions regulated by the BSRB. And there was a request for a bill introduction by a lobbyist whose name is Travis Lowe. He made a bill introduction request on behalf of a group called Acadia Healthcare. And his bill introduction request was basically to have a bill come forward that would create a new level of addiction counseling licensure called apprentice addiction counselors. That bill introduction request was received by the House Health and Human Services Committee, and it took the form of House Bill 2506. And so I'll kind of walk through what's included in 2506, and we can talk about sort of how things went from there. But that's where this all originated from. So I'll share my screen here and we'll take a look at the bill. Okay, you should be able to see House Bill 2506, and the legislative process has changed a little bit over the last few years. Now they actually include who requested bill introduction, which is a really helpful thing in terms of talking to stakeholders. If you're not familiar with looking at a lot of pieces of legislation, generally it will say whether the language is amending an existing statute or whether it's a brand new statute. If it's a brand new statute, it would just be language that would be dropped in place. In this case, in section 1, it says KSA 65-6610 would be amended. And this is a statute that is currently in the addiction counseling profession. It includes a lot of the language that talks about qualifications for licensure for the different levels of licensure. And so relevant to this discussion, you don't need to worry about the entire language here. Since it's amended an existing statute, what you can look for is if there's italicized words or bolded words, that's new text. So all of this right here is existing statutory language. What the bill would do it would add new language beginning on page 4 to a new section that starts with D. And under D, it would say an individual may apply to the board for an addiction counselor apprentice license within the scope of employment at a CMHC, an FQHC, a PRTF, or private treatment facilities that are defined there in the statute. The addiction counselor apprentice license would be issued by the board if the board reviews and approves the application and the applicant has paid the fee set forth by the board for issuance of the addiction counselor apprentice license. In number 3, it would say absent extenuating circumstances approved by the board, an addiction counselor apprentice license issued to the board would expire upon the date the board issues or denies a license to practice as an addiction counselor, or 60 months, 5 years after the date of issuance of the addiction counselor apprentice license. It would further go on to say that addiction counselor apprentice license shall not be renewed or issued again on any subsequent application for the same license level. It says that will not be construed to limit the number of times someone can take an examination. Under 4, an individual shall not practice addiction counseling under an addiction counselor apprentice license unless the person is under the direct supervision of an individual licensed by the board to practice at the independent level. Under that section, it says the supervisor shall provide a minimum of 1 hour of individual supervision each week, during which the supervisor and apprentice shall review the apprentice's activities during the period. The supervisor and apprentice shall jointly fill out the required 6-month report and notify the board in writing of any change in supervision status within 5 calendar days after such change. On line 17, you can see the scope of practice for this new position, which would include client screening, assessment, evaluation, and referral, development of treatment plans and client input, case management services, individual, group, and family counseling services, documentation of client treatment progress in the clinical record, crisis intervention services, in G, development and submission of official written documentation of treatment progress and recommendations for court purposes, adherence to confidentiality requirements for client records and information, and I, adherence to ethical standards of conduct for addiction counselors. And then it says in 6, the board shall not issue an addiction counselor apprentice license to an individual who has previously been issued an addiction counselor apprentice license or temporary addiction counselor license. And then the remaining sections of the bill would add new language here, allowing for a fee to be set by the board and an amount not to exceed $100 for this new type of license. And then other standard language will become effective upon publication of the statute book, which is usually sometime around July 1st. So this is what the bill was introduced to do. We were not made aware of this language prior to the bill introduction request being made. We understand the advocates had worked more closely with representatives from the Department for Aging and Disability Purposes, and they were pursuing maybe a path of practice under that agency. But when the bill was drafted by the revisor's office, it was established as a new license type under the BSRB. So we met with them. We expressed a number of concerns. We reached out to our board chair and a couple board members. We also reached out to a few members of the Addiction Counselor Advisory Committee. There was not time for us to have a special meeting as an advisory committee to discuss this, but we didn't want to violate open meetings either. So we just talked to a couple of the advisory committee members to get some feedback in a very quick manner. But we wanted to make sure that now that things are temporarily paused, we wanted to bring it to you and kind of walk through this process. So some of our initial concerns about the bill as we looked through this new license type, the bill draft does not include specific educational requirements, training requirements. There's no mention to an individual meriting the public trust. So some of the traditional things we would expect to see are not included here. There's also some what we would think would be missing language in terms of a minimum age that someone would need to have in order to qualify for this position. There's also some references in the language here that we're not familiar with. There was a reference in one of the sections which talked about a 6-month supervision report, but we don't require that to be provided to the board for any level of license. So that was a little confusing to us. There was also a mention of a 6-month period for the issuance of the license. And that is well beyond what length of licenses we have right now. We have 2-year licenses for basically every license type and temporary license. So we had a number of concerns. It didn't match.
60 months. I
60,
think you said 60.
right, 60 months. So 5 years, which is quite a bit longer than the 2-year time period. I think there was also a question of, if there's a lack of education and training, it is concerning for the individuals to have the full scope of practice that's referenced here in the bill as well. And so we did have some conversations with Mr. Lowe, the lobbyist who had requested the bill introduction. We tried to kind of find an understanding of what they were actually hoping to achieve in terms of making this bill introduction request. The bill was scheduled for a hearing. That hearing was canceled to allow us more time to work with the advocates. We ultimately scheduled a big meeting with representatives from several different groups, including stakeholders from the Department for Aging and Disability Services, the addiction professionals, several other groups. The chair of the House Health and Human Services Committee, Representative Will Carpenter, I believe he had originally worked with representatives from Acadia, and he was very interested on something moving forward to address workforce. But as we worked through this process, the representatives from Acadia provided some alternate proposals. Some of this matched a little bit more closely to what we have under our existing license structure, such as a 2-year license that could be renewed once. But there was still quite a bit of concern about individuals providing a lot of services without having a specific educational requirement, a training requirement. We also expressed that our board, we had a real quick board meeting with the opportunity for the board to provide input. We told them that the way the bill was drafted is not how the advocates would really like the final version of the bill to be. But the problem is when you have a printed version of a bill and that's going to be up for hearing, you have to weigh in on the bill as it currently stands. And so while we wanted to work with the advocates, there's no guarantee the legislature will make those changes. That's kind of one of the things when you're working behind the scenes and trying to make sure that a bill comes forward with the right wording. Once it's out there, it's really up to the legislature if they want to make changes or not. And so we had a number of concerns. Other groups expressed a number of concerns as well. And ultimately, like I said, we had that meeting. We tried to see if we could come to a consensus on an alternate proposal, but we were all still very far apart. Another factor that's also in this equation as well is, the representatives from Acadia, they want to increase their workforce, but also they would like to receive reimbursements for individuals providing some of these services. And representatives from KDADS were basically saying, that reimbursement piece is still something that, at least as it's currently drafted, that's not something that's on the table for this type of position. The representatives from Acadia also had some language that they were using as the basis for some of this, which was from some other states. One of these was described as an unlicensed position in Louisiana. We did some research into this. Leslie pulled a number of their statutes and regulations. We called the Office of the Addiction Counseling or the Addiction Counseling Licensure Board in Louisiana. And I think it's complex because Louisiana's system is different than ours, but there are different things similar to what you used to have in Kansas with the counselor and training model that would still require some education and training. What was being highlighted as an unlicensed practitioner in Louisiana was really facility terminology. So it's a bit more complex than if you're just taking a piece of that puzzle. You kind of need to take the full thing. And Kansas' system is very different than some other states. And so ultimately, long story short, we were not able to come to a consensus position and agreement on something to move forward this session. And as part of this conversation, we also explored, at least with the conversation, if a new position is not suitable to be created, potentially might there be some other flexibilities that could be discussed with the existing student temporary license that was created by the board about 3 years ago. That was something where advocates had come to the board, said there was an interest in supporting workforce, having individuals begin to work in the addiction fields before they had finished their bachelor's degree. And based on a lot of the feedback and requests we had received, based on that, we had developed that student temporary addiction counselor license. And over the past 3 years, from our perspective, it's been very popular and successful. I think we have about over 50 people who currently have a licensed student temporary license for addiction counseling. There's other individuals that have previously held that no longer hold an active license because they've been able to successfully transition to a addiction counseling license after they graduated. So I guess I wanted to bring this to you and explain how we got to this point, and then also let you know that as part of this conversation, potentially there could be some interest in having more flexibility for the student temporary addiction counselor license. Ultimately, Representative Carpenter decided not to have the bill move forward to a hearing, but what he wanted was a letter of support for the stakeholders and advocates to continue working together with a goal of coming to a consensus alternate proposal by the end of July. And so we wanted to bring this to you, make you aware of all of this information. Also to bring back the student temporary license to you as well, so that statute relevant to that is included in your packet as well. And I definitely want to turn it over to all of you for some questions and discussion. But what we hope to accomplish is allow you to receive the information today, be thinking about where we can go from this as an advisory committee, have another meeting in June, and really kind of work on some of these topics to see if there can be something that we could potentially propose to the legislature for next session as something to address workforce that could be involved in these areas. There is also the ability potentially as an advisory committee, if you think it would be helpful to hear from the advocates of the original bill, Acadia, if you would like for them to be invited to come to our next advisory committee and share maybe their thoughts or their interest in why they were requesting this bill to begin with, that is something also. So if you think that would be beneficial to hear from them in terms of what they wanted to achieve, I could reach out to them in between this meeting and our June meeting, and then see if they would be interested in coming and talking to the advisory committee as well. So I'll turn it over to all of you and feel free to ask any questions about any of this. I realize it's a lot, and I've been trying to provide a couple of updates here and there. For some of you, this is probably a lot of new information. For some of you, you were probably aware of most of this, but I wanted to make sure that everybody was on the same page before we went forward as a committee. Any questions or comments? Yep.
I'll jump in. I've been following this pretty closely, and what it does is strips away all education and work requirements in order to enter the field, so somebody can begin practicing doing the full scope of addiction counseling tasks on day one of walking into an organization under supervision. And it threatens, in my opinion, the quality of the workforce to a considerable degree. It also has some functional challenges, even with reimbursement. An update, KDHE has said it's going to be at least a couple of years before they could even visit restructuring to be able to provide Medicaid reimbursement for it. Commercial payers certainly aren't going to pay for it. And that's just from a kind of a provider perspective. So I think Acadia Healthcare is an OTP, an opioid treatment provider, and I think they face some unique workforce challenges. You can in their defense, and I think it just has to do with the nature of the work, the hours of operations, and things like that. And so they are pressed, I think, a little bit harder with workforce issues than even other providers. And then, CCBHCs have had enhancements that have allowed wages to increase. Even people within the block grant network got some workforce development dollars, things like that. And Acadia has been left out of all of that. And so what I have wondered and have talked to some colleagues from Oklahoma where they experienced something similar is if something couldn't be created specific to OTPs that would help address their workforce challenges without creating a license type that is going to impact the provision of addiction counseling services across all settings across the state. That's my 2 cents.
I guess just to just some initial thoughts that we've moved in Kansas, right, from a system where we didn't have as many requirements and there was certification once. Now we moved to licensure, which I think, to me, it's also valuing and acknowledging the need to have competent individuals providing care for this disease. And that when I agree completely, when we start to strip away some of that, I think it has implications on also how we value the people that are accessing care. That we would never say, well, there's a shortage for diabetic providers, so we're just going to remove the requirement to have a doctor, have an MD prescribing to them. I think I acknowledge, and it's been an issue in the rural areas for decades, the workforce issues, and it's facing epidemic proportions now. I don't know that this is the solution that we want to go down this route. I think it's good to look at creative ways. I feel like we've been talking about that. We talked about, you know, student pathways, creating pathways to allow students. We spent a lot of time on that, trying to open that up. We also have ability for peers, you know, individuals with lived experience to, you know, and that's a different licensure, or, you know, ability to contribute to a treatment team, to the overall comprehensive nature of addressing someone's, you know, care and treatment. I guess I just also echo the concerns with this, David. And I guess I do wonder, you know, this the request to collaborate, always good to collaborate. Also recognizing what we've already done. And again, are there something, I like that where you said, like, could we look at some, you know, even further? We did talk a lot and put a lot of time into the student changes to try to make that a little more accessible. I guess I'm just wondering what if it's workforce shortages, that's kind of universal. You know, I don't know that opening licensure is the addressing that. There's a lot of different ways that we could creatively address that don't have to do with licensure. So I don't know. These are just thoughts, I guess. That's not a plan for moving forward, but just I guess, yeah, very concerned about that as well.
Oh, and in our conversations too, there seemed to be a little bit of a divide as well, because it sounded like the facility would love to be able to hire individuals that could be reimbursed for providing all those services. At other times, it sounded like the facility wanted people at a very low level that, in their words, could do more than answer the phone. And so we talked a little bit about, okay, well, what you have described here is not not that lower level type position. And I know that there are some other groups that have worked on lower level positions. I think that there is a mental health technician program under the Board of Nursing, and I know that that's being expanded. I think in Wichita, as they're getting ready to open up the new mental health hospital in South Central Kansas in preparation for that. So it may be something, it's not under the BSRB, but it did make me wonder about, you know, that program as well that exists out there.
Again, that makes sense to me, Dave. If we think about on the medical side, there are CNAs, there's CMAs, there's, you know, there are different levels and something like that to me. But when it says evaluation and assessment,
And
like that's different to me. Than, you know, even that versus running maybe, you know, a group, or having other case management, that again, those are very different skill sets, I think. And so, you know, maybe if that was a direction we were going, is to look at maybe a level, not to equate with like an, you know, an LAC or LMAC, but to say, okay, there's a level of services. I think it gets back to what Jason was saying though about reimbursement. Like you can create it, but doesn't mean it's going to get paid for. I don't know what that how helpful that is. I wouldn't know on that, but those are, I guess, some thoughts too.
I think the pay structure for OTPs is a little bit different than it is for most other providers, provider types, and so I don't think the pay structure is the reimbursement issue is significant for OTPs. I'd really like, if we have an opportunity between now and next month, to see what it is that Oklahoma did exactly. In that, as I was talking with a colleague who is in OTPs in Oklahoma and is now in Kansas, it was at least his opinion that was effective, without diluting too much. I also think you'd mentioned assessment and evaluation, Christina. I think that there could be a role for folks in that who may not be LACs. And part of it is that the statutes are pretty prescriptive in what's in an assessment. And so the assessments are really structured interviews. And so Now, how that information that's collected is interpreted and what recommendations are made off of it, that's a clinical piece. But as far as collecting that information, getting the data, I think that's something that there could be some flexibility on that may relieve some of the issues that I've heard Acadia say that they're having.
I guess my thought is, does this person that they're trying, if this is what's happening, the person that they're trying to see, does this person have to be licensed, or could they not get a person that could be just certified through KDADS? If this particular type of person that they're trying to see at this particular level, that doesn't need to be a certain educational level, why wouldn't they just be able to be certified through a KDAD certification, like a behavioral health technician or a mental health technician or something like that, or whatever, I'm just trying to like, is there a certain reason why this person needs to be licensed at the BSRB level? It's like, maybe that's the level for reimbursement. I don't know. I'm just saying, like, why are they going through this level to get that, so that's my question.
I think if you look at the legislation that was proposed and what they were saying that they wanted folks to be able to do, it's the full scope of addiction counseling services.
Yeah.
I have another question about reimbursement too. So, I hear that Medicaid or KDADS is saying that this might not happen for a few years. I wonder for FQHCs and for CCBHCs that get paid on the prospective payment system and they have a base rate, whether or not incorporating the cost of this kind of employee could be included in calculation for that base rate. And is that a way that they're thinking they can get reimbursed? And that would be only for CCBHCs and FQHCs. Just a question, something to maybe look into.
As we're almost out of time for today's meeting, do you feel that there'd be any benefit to hear from Acadia directly to our committee? Because there's a lot of things in this that I disagree with from a professional standpoint and a protection of the public standpoint.
I visited with Acadia and it was helpful for me to hear from them because I think it provided clarity with what it is that they're trying to accomplish. And I think that may be of benefit for folks on the advisory committee to hear.
I think it would be a good idea to understand, like Jason said, what hole it is that they're trying to fill, because there may be another solution if we just really understood what it is that they're struggling with.
David, would you be able to reach out to those folks?
Yeah, I'll reach out to Travis and then coordinate something. We'll need to do a poll for our next meeting date. And so once we have that established, I'll reach out to them and see if they can come and visit with us. So
Okay. David, I realize we're out of time, but did you want to say something about new advisory committee members?
sure. So in the spring, terms for advisory committee members usually go by fiscal years, and it's a 2-year term. And so looking towards the end of June, one member of the advisory committee will have served 4 terms, which is the max that people can serve, and that's still Sanea. And so she will need to come off the advisory committee at that time. Traditionally what we do is if there's an opening on the advisory committee, we basically offer to provide a letter or a message out to all licensees to say if you're interested in serving on the advisory committee, please provide a letter of interest and a current resume or CV. And then those can be distributed to all of you as current members before your next meeting. And then you can come to that meeting ready to discuss a new member of the committee or recommendation for a new member. So if you don't have any objection to me continuing to do that process, I'll plan to do that between now and your next meeting so that you can review applicants at your next meeting.
Is that good with everybody? Okay. Looks like there's consensus on that one. David, you mentioned sending out a poll for our June meeting. So be looking for that in your email. And we are 12 o'clock on the dot. The next item on the agenda is adjournment. Would someone motion to adjourn the meeting, please? Is
So moved.
there a second?
Seconded.
Okay, motion to adjourn the meeting has been moved and seconded. All those in favor say aye.
Hi.
Aye.
All those opposed, same sign. I appreciate you all's time a great deal. Thank you very much and have a good spring. We'll see you
Thanks.
soon.
Thanks, everyone.